So here's our clinical roadmap for today's explainer. First, anatomy of the venous systems. Second, pathophysiology and signs. Third, diagnostic tests. Fourth, interventions. And finally, number 5, complications.
Section 1. Anatomy of venous systems.
Any good surgeon will tell you that you absolutely have to understand the plumbing before you even think about fixing a leak, right? So let's look at how the lower leg divides up the work. We've got 2 main systems fighting against gravity here. The superficial venous system carries about 20% of the blood, and it flows from below strictly upwards, totally one way. But the heavy lifting, that's done by the deep venous system. It handles a massive 80% of the blood through 3 distinct pairs of deep veins.
Now, connecting these 2 separate systems are what we call perforators. You can think of them like one-way security doors. They make absolutely sure blood only ever flows from the superficial system right into the deep system. And while we always hear about the famous named ones for exams, the Hunterian in the thigh, Dodd above the knee, Boyd below the knee, and Cockett just above the medial malleolus, it's actually kind of wild to realize there are somewhere between 100 to 150 of these perforating veins in total.
Section 2. Pathophysiology and signs.
Alright, so now that we know how the plumbing is supposed to work, what exactly goes wrong? Well, first, we need to get on the exact same page with our definitions. Clinically speaking, varicose veins aren't just, any visible veins. They are very specifically defined as dilated, tortuous veins that are greater than 3 millimeters in diameter, and they're caused entirely by defective valves. It's a precise, measurable, mechanical failure.
And size matters immensely here, because the diameter of the vein completely dictates our clinical approach. Varicose veins, which are over 3 millimeters, represent a true functional problem. But reticular veins, those sitting between 1 to 3 millimeters, and dermal flares or thread veins under 1 millimeter, those are predominantly just cosmetic blemishes.
So why do these specific veins dilate so massively in the first place? It really all comes down to the ambulatory venous hypertension theory. See, normally your leg muscles act like this amazing anti-gravity pump, just pushing blood up and out. But when those valves we talked about become defective, the blood refluxes. It actually flows backward. And this massively increases the pressure in the superficial venous system. Basically, the biological pump has just completely failed.
Now when we're assessing that clinical damage, we use the CAPP classification, which is graded from C0 all the way to C6. The really critical late-stage ones you want to watch out for are C5, which is a healed ulcer, and C6, an active venous ulcer. And here is a golden rule for your clinical exams. If a patient presents with multiple signs, let's say they have pigmentation and a healed ulcer, you absolutely must score them based on the highest clinical value present. Always go with the highest one.
Moving on to Section 3, diagnostic tests and ultrasounds.
Okay, so how do we spot the exact point of failure before we even think about operating? Well, we use the Trendelenburg test. Try to vividly picture this. First, you elevate the patient's leg and literally milk the veins to empty them completely out. Second, you tie a tourniquet just below the saphenofemoral junction. Third, you have the patient stand up. And finally, you just observe the leg. If you see this rapid filling of the veins, well, you know exactly where the mechanical incompetence is.
But listen, before you even think about picking up a scalpel, you absolutely have to perform the modified Perthes test. This is incredibly crucial for ruling out deep vein thrombosis, or DVT. Just think about the mechanics for a second. If the deep veins are blocked by a clot, and you go in and surgically remove the superficial veins, you've just left that entire limb with zero venous drainage. It's a catastrophic error that can literally lead to massive edema and even gangrene. So we always rule out DVT first.
Now let's test your clinical eye for a quick second with an imaging question. When a radiologist is performing a venous ultrasound, they're actively looking for something called the Mickey Mouse sign. Any idea what exactly they're looking at?
The anatomical answer is actually pretty fascinating. So on a duplex scan, this Mickey Mouse sign is formed by 3 key structures: the great saphenous vein, the femoral vein, and the common femoral artery. When you look at them together, their cross-sections perfectly mimic the silhouette of, well, a famous cartoon mouse. It's exactly how they confirm they're in the right spot.
Section 4. Surgical and modern interventions.
Once we've accurately diagnosed the problem, it's time to actually fix those defective valves. Now, historically, the traditional go-to surgery was Trendelenburg's flush ligation and stripping. This literally involved tying off the junction and aggressively stripping the vein right out of the leg,
Pretty intense, right? But today, the gold standard has dramatically shifted over to modern procedures. Things like endovenous laser therapy, or EVLT, and radiofrequency ablation.
So why the massive shift? Well, EVLT and RFA offer some seriously huge advantages. We're talking way less recurrence and much faster recovery times for the patient. Instead of physically removing the vein, they rely on inserting a probe and using intense heat or lasers to literally collapse and seal the vein walls from the inside out. Oh, and a quick clinical detail for you, lateral firing lasers are usually preferred here because they provide the most uniform distribution of heat. That safely minimizes the risk of actually perforating the vein.
Now, for the smaller veins, we use foam sclerotherapy as a chemical alternative. Using what's called Tesserae's technique, we mix 1 part chemical sclerosant with about 3 or 4 parts air to create this really thick foam. It allows for excellent distribution, but, and this is a big but, notice the strict limitation here. It is only viable for veins less than 3 millimeters. You absolutely cannot use this on large, true varicose veins.
And finally, Section 5, Complications and Venous Ulcers. Unfortunately, when these defective veins are just left untreated, things can get pretty severe. Advanced late-stage venous disease actually presents with some highly memorable diagnostic markers. You might see corona phlebectotachia, which is this fan-shaped flare right by the ankle, or atrophy blanche, which is a stark, pale white area surrounded by little thread veins. But honestly, the most striking one is lipodermatosclerosis. This is where the fat completely obliterates, giving the leg this really hard, woody feel. It creates a very distinct, unforgettable, inverted champagne bottle appearance.
But the most common, and arguably the most painful complication, is the venous ulcer. These are typically shallow, they have sloping edges, and they are almost always found in the gaiter area, right by the medial malleolus. To manage them, we usually don't go straight to surgery. Instead, we use Bisgard's regime. This relies really heavily on strict multi-layered compression bandaging to physically counteract all that underlying venous hypertension we talked about earlier.
So the really crucial point here is what happens to those ulcers over time if they just get ignored. A long-standing chronic venous ulcer can actually undergo a malignant transformation into what's known as a Marjolain's ulcer. And this is an aggressive squamous cell carcinoma. If this happens, the treatment is immediate surgical excision. And get this, radiotherapy must be actively avoided here because ironically, it can actually make the cancer return with an absolute vengeance.
Okay, let's wrap this up with one final, kind of tricky clinical scenario to really test your understanding of everything we've covered. Imagine a patient comes in with severe varicose veins, but their diagnostic tests reveal they have a super rare condition called Klippel-Trenaunay syndrome. So, how do you surgically treat their varicose veins?
The shocking answer? You don't. See, in Klippel-Trenaunay syndrome, the deep veins are completely absent from birth. Those torturous, painful, superficial varicose veins we want to get rid of, they are literally their only possible avenue for venous drainage. If you aggressively strip them, you destroy the limb. They have to be managed strictly conservatively. It really makes you think, doesn't it? We take the hidden, complex plumbing of our bodies entirely for granted, right up until we see what happens when it stops working. Anyway, thanks for joining me on this deep dive. Keep learning, stay curious, and I'll see you in our next explainer.